Welcome to the Trauma Insights podcast. Today, we're diving into a comprehensive collection of case scenarios that really put the ATLS approach to the test. It's a real deep dive into everything from blunt trauma to pediatric injuries, thermal burns, even complexities in pregnancy and geriatric trauma. These cases, really underscore that trauma management isn't just following a checklist. It's about integrating clinical reasoning with decisive action under pressure.
Right, and what stood out immediately is how the cases start with the basics, the primary survey ABCDE. They show us that even familiar steps, like airway protection, require constant vigilance. And then there's the discussion on sequential priorities, which serve as the backbone of successful trauma care. It's like...
Oh yeah, exactly.
You see how every case emphasizes that you can't simply memorize protocols. You need to think and adapt, almost like a mental chess game in the chaos of the trauma bay.
One fascinating aspect is the emphasis on scenario variants. For instance, take the blunt abdominal trauma cases. They cover everything from splenic injuries with a CARES sign to delayed presentations that could easily be misinterpreted if you focus only on vital signs. They remind us that elderly patients on beta blockers, for example, might not show the expected tachycardia even with significant blood loss.
Right, and that's so critical because if you rely solely on the numbers, you might underestimate shock in someone whose heart rate doesn't ramp up due to medications like metoprolol. It really forces us to look at the whole picture: skin perfusion, mental status, pulse pressure. It's a meticulous balance
so many pieces
between
of the puzzle.
Objective data and clinical gestalt.
And then there's the series on airway management. I found the detailed discussions around facial trauma and inhalation injuries in burns especially gripping. The scenarios remind you that early definitive airway management, using techniques like RSI, videolaryngoscopy, and even preparing for cricothyroidotomy, is absolutely, non-negotiable when signs like stridor and carbonaceous sputum are present.
Right, and the cases do a great job of showing what can go wrong if these steps are delayed, particularly in the context of, say, circumferential neck burns. Speaking of burns, the collection really drives home important nuances. For instance, the discussion on large TBSA burns and how the rule of nines is used for quick estimation, it's almost like a rapid mental calculation to guide the Parkland formula. And then there's the aspect of ensuring the airway is managed first because of the risk of Escher formation causing chest wall restriction.
Yes, and that part about escharotomies is quite striking.
Make those incisions to relieve tension, especially in circumferential burns where, ventilation can deteriorate rapidly.
Moving on to pediatric trauma, the cases really differentiate between mechanisms in infants and older children. They illustrate, for example, how a seemingly minor fall in an infant might trigger a completely different approach because of the unique physiology. And they also address the controversy over when to obtain a head CT versus observing carefully using clinical decision rules like PCARN.
Yeah, and it's so interesting because while a GCS of 15 is reassuring in one child, in another scenario, the history of even a brief, stunned period following a fall becomes a red flag. The details, such as even a single episode of vomiting in the context of head trauma in infants, are emphasized.
That's what really underscores the necessity of tailoring our management to age-specific factors. And then the collection doesn't shy away from addressing more challenging areas like electrical injuries and chemical burns. It's pretty eye-opening to see how a small entry and exit wound from a high-voltage shock can hide devastating internal damage like rhabdomyolysis.
Exactly. When you think about the potential for myoglobinuria and subsequent acute renal failure, it's a, critical reminder to always screen for muscle injury, even when the skin findings are subtle. Not to mention the chemical burns. The protocols for ocular exposure to sodium hydroxide are, extremely detailed. They drill into the importance of copious irrigation and the need to avoid neutralizing agents that might exacerbate tissue injury by causing
Right?
exothermic reactions.
And they meticulously advise using specialized devices like the Morgan lens to ensure proper ocular irrigation. That level of detail is vital when seconds matter and every minute of chemical exposure counts. Then there are the scenarios involving spinal trauma. I really appreciate how the cases differentiate between complete injuries, like a full cord transection, versus incomplete injuries such as central cord syndrome and even Brown-Séquard syndrome. The explanations really help, clarify why, for example, the return of the bulbocavernosus reflex signals the end of spinal shock.
Yeah, that's a key teaching point.
It's all about understanding not only the injury itself, but also the expected time frame for physiological recovery.
And there's a clear focus on the need for immediate, decisive communication, especially during team or interfacility transfers. One of the cases really drove home the pitfalls of poor handover, where incomplete information can seriously delay treatment.
Absolutely, and it emphasizes
Without that
using
clarity,
structured communication
it's almost
formats like
trying to
SPAR.
navigate an already chaotic situation with an unreliable map.
Exactly. And in the transfer cases, the documentation and direct physician-to-physician communication are not just bureaucratic steps, they're life-saving measures. For instance, when a patient's head, CT, shows a significant subdural hematoma, delaying the transfer because you're too busy placing a central line is not acceptable.
You focus on immediate
It has to be a
stabilization and then
coordinated
rapid
dance
transfer.
between the sending and receiving teams.
On that note, I found the discussions about air transport particularly compelling. They remind us that even a small pneumothorax can become catastrophic in helicopter transport due to altitudinal pressure changes. So, placing a chest tube prophylactically is, absolutely essential.
Yeah. There's a fine balance between over-intervening and acting preemptively. And then zooming into injury management in special populations like the elderly and pregnant patients, those cases are packed with nuance. For example, in geriatric trauma, the cases repeat that normal vital signs might be deceiving due to factors like beta blocker use and decreased physiological
and even
reserve.
a seemingly normal blood pressure
It really
could
underscores
actually
the
be
importance of
relative
understanding the
hypotension in an
patient's
elderly
normal
patient used to
baseline.
higher baseline pressures. Similarly, trauma in pregnancy adds another layer of complexity. The scenarios discuss placental abruption, the need for continuous fetal monitoring for at least 4 to 6 hours, and even the fascinating point about manual left uterine displacement to prevent aortic wall compression. It's a comprehensive view that
Yes,
reminds
and it goes
us
on
how
to address when
multitasking a
ROGAM
trauma
is
team
indicated
must
in the
be.
context of blunt trauma. And then there's the section on intimate partner violence and elder maltreatment. I find it so important that these cases include not only the clinical findings, but also the behavioral red flags. For instance, a partner answering all questions, or the presence of grab marks are classic signals that
And then
abuse
it
might
naturally
be
flows
occurring.
into the responsibility of
It's a
healthcare
reminder
providers to
that
report
trauma care
suspected
isn't
abuse.
isolated to physical injuries. It also involves the social and ethical dimensions.
Indeed. And speaking of social dimensions, the long-term follow-up portions, like the discussion of pediatric growth plate injuries, are vital. Understanding the Salter-Harris classification reminds us that even when the immediate fracture is managed, the risk of growth disturbance is real.
Right? Those potential
really
limb length
emphasizes that our
discrepancies
care
or
extends
angular
far beyond the
deformities
initial
might not
emergency.
be apparent until months or years later. One thing I sometimes find challenging, though, is the integration of all these diverse scenarios into one coherent practice model. It seems almost overwhelming at first.
I hear you, but that's precisely
They
the point of
compel
these
us to
scenarios,
internalize
isn't
a
it?
systematic approach while remaining adaptable to the unpredictable nature of trauma care.
Exactly. And it's also interesting to see the evolution of our tools, from traditional physical examination to incorporating advanced imaging studies like CT angiography for blunt cerebrovascular injuries, and even utilizing length-based resuscitation
Yeah,
tapes
it's like
for
an ongoing
pediatric
conversation
patients.
between
Each
technology
case
and clinical
reinforces
expertise.
the idea that the fundamentals remain constant, but the tools and nuance can be incredibly varied.
One area where I had a moment of reflection was the discussion on fluid resuscitation. The cases delve into adjusting fluid rates based on urine output rather than fixed formulas. And in burn management, it's emphasized that the Parkland formula is just a starting point.
And the need to
It's that
titrate
dynamic
based on
adjustment
patient
which can be
response rather than
life-saving,
relying solely on the
particularly in
calculated
patients
value
with
is
multiple
crucial.
comorbidities like CHF or COPD.
And let's not forget the scenarios involving resuscitation endpoints. The cases focus on lactate clearance, base deficit, and even the recognition that sometimes invasive monitoring might be necessary truly reflects modern
Yep,
best
it's all about
practices.
evidence-based care in real
It
time.
reminds us that our interventions must be continuously evaluated as the clinical picture evolves.
Overall, this comprehensive collection by Dr. Atef Ahmed really encapsulates the spirit of ATLS, structured yet flexible, systematic yet individualized. It pushes us to be better clinicians by combining rigorous theoretical frameworks with the messy reality of actual trauma scenarios.
Yeah, it's a
I mean,
robust resource
when you think
that
about
not only tests our
the sheer
knowledge but
variety
also hones
from
our
electrical
clinical
burns
judgment.
to penetrating trauma in pregnancy, it's like a masterclass in adaptability.
One key takeaway for me is how each case emphasizes decision points that are not black and white. There's often respectful debate in the literature about, for example, whether to intubate early in certain facial burn scenarios or how aggressively to reverse anticoagulation in elderly TBI cases. It's essential to weigh guidelines against
Right.
real-time assessment.
And that's where our
sometimes
clinical
limited
acumen
resources.
really gets challenged. I also appreciate the strong focus on communication, both within the trauma team and during inter-hospital transfers. The structured SPA format and clear physician-to-physician handoffs can really make a difference in outcomes.
Yep, that part really resonated.
It's a reminder that in trauma, communication isn't just a courtesy, it's a critical component of patient safety.
In sum, these case scenarios provide an excellent forum for repetitive learning and internalization of trauma protocols, while challenging us to think beyond memorization.
Absolutely.
They compel us to integrate our knowledge, think critically, and most importantly, act swiftly and decisively in the face of chaos.
And I think what really ties it all together is the underlying philosophy that these scenarios are designed not just for exam preparation, but for real-life application. It's about transforming theory into effective, life-saving action
Definitely.
in the trauma bay.
It's about making the connection between classroom learning and actual patient care. To wrap up, whether we're discussing the pathophysiology of neurogenic shock and spinal injuries, the delicate balance required in fluid resuscitation, or the ethical imperatives in cases of suspected abuse, this collection serves as a reminder that trauma care is as much an art as it is a science.
And it's our responsibility to continuously improve our practice by learning from such detailed and realistic scenarios. That's all for today's episode of Trauma Insights. We hope that our discussion has shed light on the multifaceted nature of trauma care and the critical decision-making processes that underpin ATLS. Keep integrating, keep questioning, and most importantly, keep refining your approach in the field.
Absolutely. Thanks for listening, and we look forward to our next deep dive session.